So hello and welcome to this ARMA webinar on women and axial spondyloarthritis, diagnosis and management. ARMA webinars are free to access thanks to the support of our sponsors, and we would like to thank UCB for supporting this webinar. UCB have had no editorial control or input into its development. My name's Sue Brown and I'm the Chief Executive of the Arthritis and Musculoskeletal Alliance, ARMA. We're an umbrella body that brings together patient and professional organisations to work for better health services for people with MSK conditions. The average time to diagnosis for axial spondyloarthritis is 8.5 years. And there are lots of reasons for this, but for women, one of those reasons is that it is assumed that it is a disease affecting only men. There are also issues that women are more likely than men to experience inflammation rather than fusion. And it's really important that we understand the differences both for diagnosis and for management. And that's why we're absolutely delighted to have so many of you here to hear from 3 consultant rheumatologists with real experience in these issues. So thank you all for joining. And I'd like to begin by introducing Dr. Helena Maza-Ortega, who's a consultant rheumatologist at Leeds Teaching Hospitals NHS Trust, who is going to talk about what to look for, key differences in diagnosis and treatment between men and women. Helena.
Thanks very much, Sue. I'm just going to share my screen so I can show you a few slides on this extremely important subject, I find, which is, understanding the conundrum of sex and gender differences in axial spondyloarthritis. And I've included both words on my title because I think it's important, to understand that sex and gender are not exactly the same and they don't exactly correlate. So whereas sex, tends to be genetically determined and is what your chromosomes dictate, gender has got a more a wider meaning, and incorporates also other considerations, not only social factors, but the attributes that we ourselves, refer to us. So for instance, there's a lot of talk these days as to how people want to be addressed, what sort of pronoun they want to be referred by. I can share with you that I'm definitely a she and my pronoun is her. So things that we need to have into consideration, many. I think it's no good news to be a female in the context of such a male-dominated inflammatory arthritis such as Axial SpA. And I say it's male-dominated because for many, many years, we didn't even consider that females could be affected by the condition. And also traditionally, rheumatologists looking into this disease have traditionally been men. I can tell you that because I've lived, the situation of being in a room completely surrounded by male rheumatologists talking about female issues. So axial spondyloarthritis affects all comers from a very young age, whether they're females or males. Some of the data published recently has suggested that perhaps we tend to see more representation of the female phenotype in the non-radiographic subgroup of the disease, which tends to be the earlier group. Some of the non-radiographic of the people fulfilling the non-radiographic category may actually never completely evolve into the radiographic category. We still don't completely understand that. But I think the only reason why we see females more represented there is because we are getting better and better to identify the disease. There may also be the factor that, the genetic predisposition affecting females may not just lie only within the B27 histocompatibility complex, but, it may be on other factors. So women tend to progress far less than men, and they tend to progress far slower too. So this may be one of the reasons why we tend to think that males tend to belong more in the aggressive or radiographic category. But however we look at it, whether it is early or late disease, what we have to live with is with the shameful reality that we are really bad at diagnosing this condition. We don't have pathognomonic criteria, we don't have symptoms, signs that are completely specific, we don't have biomarkers, and this makes the diagnosis really difficult. Because, we have to think not only about clinical symptoms, but about laboratory tests, imaging. There's lots of things that can help with the diagnosis, but there's not one single thing that will give us the answer. The commonest presentation for people, with this condition is back pain. And we all know that back pain is really common. The majority of people presenting to general practitioners in the Western world come because of back pain, yet only a minor proportion, less than 5% in the Northern Hemisphere, will end up having an axial spondyloarthritis. So if you look at the data, you cannot contest this. Rheumatoid arthritis presented to an early synovitis clinic would take a mean of 2 years to be diagnosed. We take a little bit longer with psoriatic arthritis, nearly 4 years. But if you look at axial spondyloarthritis, at the moment, the figures are, as Sue said, around the 7 to 10 year landmark. So I don't think we are doing very well here. Now, if you think about where are people during those years of which are experiencing pain, but they are not necessarily being seen by secondary care, we can see that females tend to hang around the system for a much longer period of time. So they may present to their GP more often, yet not being referred on, or they may be referred to the MSK interface, or they may have seen an orthopedic surgeon, or perhaps a dermatologist, or so on and so forth. They tend to utilize the system much more, and they tend to take much longer to arrive to the proper place, which should be the rheumatology secondary care setting. And why is this? Well, they do present differently. Women tend to have more subjective disease activity, so they may complain, for instance, of a lot of pain burden, or inability to do things, or difficulty to be able, to mobilize in the morning, more morning stiffness, but they may not necessarily have much to be seen. So in some contexts, it has been reported that females may present with more inflammatory arthritis, for instance, but this is not something that has been seen in every cohort. Usually at the time you develop inflammatory arthritis is the time in which you get referred. So that is not necessarily bad news. But in general, women develop pain and functional impairment at a very early stage when we don't have that much objective to be seen. Now, when we look at data coming from real life, and this is data coming from the Corona Registry, I'm sure a lot of you would be familiar with this registry, which is based in the States and is covering not only axial spondyloarthritis, but also psoriatic arthritis patients. Now, people in the Corona Registry, particularly women, they find themselves and report themselves to have more disease activity all throughout from presentation and the disease course, and they tend to run into work productivity issues much earlier than men. So by the time females present in the secondary care setup, they tend to be work unstable in a larger proportion than what men do. So the overall disease burden for females is much more significant. And when we think about treatment, because we know now that we can treat this condition very effectively, and a lot of you would be thinking, well, what about biologics? And we have got some studies, that have looked at differences in the gender response. And it's really disappointing to see that, yes, females tend to do far worse with biologics. And this is data coming particularly from TNF inhibitors, in that they do not seem to attain the same level of depth of response, and they don't tend to last that long on the treatment. So they're more likely to be switching treatments because of secondary non-response, meaning lack of efficacy, or because intolerance. And why is this? So, I'm sure that you all have to agree with me that, they're not making this up, are they? A lot of the literature has been dismissed, some of this data by scientists saying, well, okay, so could this be that females tend to have more enthesitis, which we know is true, but could it be that they also have more fibromyalgia? And no, that's not the case. Fibromyalgia is common in axial spondyloarthritis, the same as is common in early other inflammatory arthritis. But females, don't tend to have more fibromyalgia, or the fibromyalgia does not need to take or to make symptoms worse. And, the converse is also true. People with fibromyalgia don't necessarily have axial spondyloarthritis. So there may be more to it. And what I think is lacking here is we're not doing the studies in the right way to address this issue. So for instance, if you think about female and male bodies, they're obviously different, aren't they? Now, if you think, simple things such as the size of the kidneys is different. Females have smaller kidneys, they have smaller livers, they tend to have higher pH in the stomach. So they're more likely to develop gastritis and, an intolerance when the treatments are administered via oral route. And we also know that the higher body fat percentage may be different. And I'm sure that you have all seen, the situation in which females around the time of, the change or the menopause, as they put weight on, they tend to become less responsive to drugs. Yet we are not doing, the trials that are giving us this information. Now, if you think about the immune system, it's obviously different too. Now, young males tend to have very high inflammatory responses after infections. They tend to arrive to to intensive care more often. You only need to look at COVID to see how the inflammatory response is different, and males tend to be more affected. Whereas females tend to be more on the immune side. There is hyperactivity of the immune system. Lupus is more prevalent, for instance, in women. Thyroid problems are more prevalent in women. Celiac disease and diabetes can also occur more frequently in women. So what I think is really unfair that we're not paying attention to these differences, and we're not designing clinical trials in the right way to address these differences. And if you think on the data that has been published on the big phase 3, phase 2, even phase 1 trials, drugs are usually tested on male mice. If they go on to the human phase, they tend to be tested more often in male healthy individuals. Very rarely you would see a study in which there's been correction made for dosage according to body weight and gender. And certainly it's extremely rare to see any of these sex or gender corrections being performed in post-marketing studies. And there is something else that we need to have in consideration, is that, ladies and gents, the world is made up by half and half. Yet we don't tend to treat females as different from male, and they are. Now, if you look at a woman's journey, it's definitely not linear. From the time, women go through the puberty, the reproductive years, they hit the menopause, along all those years, which is in the majority of cases, the majority of a woman's life, the majority of time, people experience very many changes to their immune system, and we don't completely understand those. So the role of hormones is very important, and we're only just starting to understand, the impact that they can make, for instance, in the menopause. Now, women who are going through their sexual reproductive years, we need to have a lot of things in consideration at the time of choosing treatment, for instance. And they do have also a lot of fears around the fact of what impact can the inflammatory arthritis have on the possibility either to conceive or to carry a pregnancy, to good end. And certainly in the context of axial spondyloarthritis, we do not have many studies that, help us illustrate this, although they are coming more and more. But we know that some people tend to do very well, for instance, when they're pregnant, whereas others, tend to report a lot of very significant and severe flares. So all these things need to be taken into consideration, and they should always form part of our communication stream with the patient. Now, we cannot treat a patient correctly if we don't talk with them about their hopes, their fears, their expectations. And we always have to think about people affected by a disease, not necessarily as a patient. They are patients, but they're also people affected by the disease. And each of them will have individual needs. So I think to summarize is we mustn't forget that we're still very much in the infancy, I think, of axial spondyloarthritis, although things are progressing at a very good pace now, in my opinion. We still have many foes. Delaying diagnosis is massive across the board, but it seems to be even greater in women. I didn't tell you before, but if you think about the delay of 7 to 10 years, if you're a female, add 7 to 10 months extra to that delay, because that's what the data says. In general, women affected by Axial SpA experience higher burden of disease and much more reduced quality of life than their male counterparts. They really do draw the shortest straw at the time of treatment, because they tend to have much lesser treatment response and for a shorter time than that's seen in their male counterparts. And this makes them switch treatments and go through treatment cycles much more often. And remember, a woman's journey is not linear at all, and this needs to be in consideration, both at the time of considering, diagnosis and treatment, but also well beyond. At the time your patient presents for the first time, perhaps in primary care, you should be thinking, why should a young female come to my clinic to tell me about her back pain. Surely she's got better things to do with her life. I really need to think and try to discern whether this back pain could be inflammatory, whether this is a first presentation of a condition such as axial spondyloarthritis. So just a bit of a whistle-stop tour, but I hope I've given you some hints there as to why women are even more special than you've thought before. Thank you.
Thank you very much, Helena, for that really useful introduction to the topic today. And you mentioned pregnancy, which is, of course, an important issue in relation to women. Last year, ARMA delivered a webinar on the issues around pregnancy and women with inflammatory conditions, which you will find on our website if anyone is interested. But back to today's webinar, I am now going to introduce Kirsten Mackay, who is consultant rheumatologist at Torbay and South Devon NHS Trust, who's going to discuss where to look and working with other specialties. Kirsten.
Thank you. Hello, everyone. I'll just see if I can share my screen. Let's hope I get this right. I've been practicing this earlier. Hi. So I'm a rheumatologist. I work in Torbay Hospital in South Devon, and I thought I'd show you a picture of our coastline. This is called Thatcher Rock, although Mrs. Thatcher has nothing to do with it. So Torbay Hospital, it's a medium-sized district general hospital, and we're somewhat interesting because we are an integrated care organisation. And really that means to say that the majority of patients in our area with musculoskeletal symptoms won't see their GPs. They'll be seen first by either community physiotherapy or I guess podiatry if they have predominantly foot symptoms. South Devon has an older population. We're not particularly ethnically diverse, and we don't have a very mobile population because generally when you come to South Devon you tend to stay because it is rather nice. Okay, now let's, all right, prevalence. Now this is prevalence of AS as opposed to spondyloarthritis, so the figures are probably a little higher. But I think my point is there are various different percentage potential rates of prevalence of spondyloarthritis. And NICE in 2008 suggested there should be an annual incidence of about 7 per 100,000 persons. And when I arrived, oops, sorry, go back a bit, there we go. I arrived in Torbay Hospital in 2005. Now I'd been a consultant elsewhere and I'd set up an AS service before. So I was quite interested in thinking about how many people were on the books with AS in Torbay when I arrived. And I did this audit and was somewhat horrified to find we only had 68 people on the books. Now, bearing in mind the prevalence rates that I showed you, then I would have expected somewhere between 200 and 875 people on the list. Now, most of the people with AS had either been discharged or had wandered off because I suspect they didn't think there was much secondary care was going to offer. You get the general gist, nobody was interested because the NAS group had folded, etc. Now, I guess in 2005, there really wasn't that much secondary care was offering because that you couldn't do in primary care because biologics were not available for people with AS at the time. And I'm using AS particularly at the moment, just because this goes back to 2005. People would have physio, hydrotherapy, perhaps stretching, long-acting anti-inflammatories, but that was pretty much the choice. But now it's a very different circumstance. There's lots and lots of treatment that can be done for people with spondyloarthritis, and particularly the more severe end of the cohort, which is a good 30 to 40% of the people we see. So I think it's terribly important that we get the message out there that people with spondyloarthritis need to be identified as quickly as possible and need to be referred to a rheumatology service because we can make a big difference. And I think preferably a specialist service if possible. So in 2005, I was wondering where I might find the patients who were clearly missing from our service. It was the obvious example of a nice tip of the iceberg. And so I thought to myself, well, a very large proportion of people with spondyloarthritis have an extra articular manifestation. About 42% according to this study shown. And it works out at about 20% of people will have uveitis at some stage in their history. About 10% or so have psoriasis, about 10% inflammatory bowel disease, about 5% have some combination of the above. And women are more prone to get extra articular manifestations. So they have more psoriasis, they have more inflammatory bowel disease, particularly Crohn's, they have more enthesitis. Men tend to have more iritis than women. And of course, the other thing to remember, it works the other way around. So if you go into, let's say, an inflammatory bowel disease clinic and look at everybody with Crohn's, they've got 10 to 20% of their Crohn's cohort will develop spondyloarthritis at some stage. And if you speak to a gastroenterologist, they will say that if that person with Crohn's is HLA-B27 positive, there's a very high chance they will be progressing on and be referred to rheumatology in due course. And as Helena just mentioned earlier on, so many of our patients have been to other specialties before they see us. And we always need to be aware of this. When we see people with chronic back pain, what other diagnoses they have, because it helps prompt us to make the diagnosis of spondyloarthritis, or at least think about it. So how do we help our colleagues identify the people with inflammatory back pain and then think about referring on to us? Well, we all know there are many criteria for inflammatory back pain. They have been published over the years, but in many respects, they're all looking at the same thing. They're looking for people with early onset of back pain and stiff back pain that comes early on in life, with back pain and stiffness that's worse overnight and first thing in the morning, that gets better with exercise and helped by anti-inflammatory medications. And this study from Braun et al. From 2011, I find quite useful. So they picked up the 5 criteria I've put in the red box and asked if people say yes to these criteria, what is the sensitivity and specificity? And you will see from this, if you get back pain under the age of 35, you're waking in the second half of the night with back pain and stiffness, you've got alternating bucket pain, you have improvement with movement rather than rest, and you improve with an anti-inflammatory drug. And if you're saying yes to at least 3 of those points, your sensitivity is about 79% that you may have spondyloarthritis, and specificity about 46%. So these are the people we should be thinking about having, seeing in rheumatology to make the diagnosis. And NICE are using exactly the same criteria. If you look at, I've summarized this from the NICE guidance from 2017, NG65. And this is looking at people who are presenting with back pain for more than 3 months before the age of 45. And if you look at the top 5 on the summary I've made, they're identical to the Braun paper. And NICE is saying, if you're saying yes to at least 4 of those criteria, please refer into rheumatology. So in an effort to try to make it easier to refer in, I came up with a direct referral pro forma. Now, I've had a number of iterations over the years. This is my current referral in, and I'm using the NICE guidance for this. And I'm asking my colleagues in gastroenterology, ophthalmology, physiotherapy to look for their patients and refer to me, or the physiotherapists I work with, if people are answering yes to the above 5 questions. And just like the Braun paper, I've said, if you're under 45 and you're saying yes to at least 3 out of the top 5 questions, consider referring in. Now, the other thing I wanted to talk about is how certain signs and symptoms contribute differently to the probability of having another underlying illness. So if you take the example of, say, CRP, then CRP does not give you a high probability of making a diagnosis of spondyloarthritis, because there are lots of reasons why people have a raised CRP, and a lot of people with spondyloarthritis don't. But if you took sacroiliitis on an MRI scan, now that's a very different story. So if we took the items that I've highlighted in red, so a person with inflammatory back pain, a previous history of uveitis, a good response to an anti-inflammatory, and happen to be B27 positive, and I've highlighted those with the red star, you add up those scores and you come up with a figure of 69. Now I'll show you what that means in terms of probability. So here's the graph it refers to, and if you look for the red star at the top of the screen, that person with the previous history of uveitis, the inflammatory back pain symptoms, B27 positive, and a good response to anti-inflammatories, there's a very high chance they have spondyloarthritis rather than another form of back pain. But if you took somebody with just some of the symptoms of inflammatory back pain and nothing else, their probability is they're very much lower. I've put that in yellow. And I thought you might like to see this dynamically. Now, there's something called the SpA tool. Some of you may have heard of. It's been done by the Royal National Hospital for Rheumatic Diseases, and it stands for Spondyloarthritis Diagnostic Evaluation Tool. And I'm hoping I'm going to be able to share the screen and show you dynamically how it works. Now, this is where we go.
Yes, we can. Oh, that's your slide, isn't it?
Here we go. Let's try that. Now, can you see my SpA tool? Okay, hang on a minute. Let's go in. No. Can I try again? This may not work.
Yeah, try again.
Try again.
It was working out. Yes, we're in now.
Okay, we're in. So this is the dynamic version of that table I showed you earlier. So let's do that one person we were talking about earlier. So inflammatory back pain, a past history of uveitis, a good response to anti-inflammatories, and who is B27 positive. So that's what I showed you earlier. And there they come on the graph. Clearly a very important person to refer to into rheumatology. But let's just take away the B27 and the uveitis. And so they've got inflammatory back pain, they're responding well to anti-inflammatories. You see how the probability reduces. If we then have a different person who has got inflammatory back pain and they've got a family history of, let's say, AS, that's their probability. So my point really is that think about the various different symptoms and signs that would make up spondyloarthritis and bear them in mind when you're reviewing your patient. Now, hopefully, I'm going to go back to my last slide. So just to summarize from my perspective, women have more extra-articular manifestations. So it's a really good thing to do to consider whether your patient is attending a gastroenterology department with Crohn's disease, as an example, or whether they're attending, they've had uveitis and they've had that diagnosed by an ophthalmologist. And I, as a rheumatologist, need to go looking in these specialist clinics for my patients if they're not in my service already. From the perspective of a physiotherapist or first contact practitioner who's seeing a lot of people with back pain, how do you weed out those with spondyloarthritis and those with mechanical back pain? Well, I would encourage you to have a high threshold of suspicion when people have a definite diagnosis of inflammatory back, Crohn's disease, UC, uveitis, psoriasis, strong family history. Those are the things to consider. And please do refer into rheumatology, because there are so many things that we can do nowadays to really make a difference to somebody's life and their symptoms. And that is pretty much what I was going to say. Do I stop?
Brilliant. Thank you very much. That's great. Thank you, Kirsten. And there's various bits in the chat about how to access the SpA tool, which apparently is spatool.co.uk, but we will include the link to that in the email that you should all get after this webinar. Okay, thank you very much, Kirsten. So our final speaker before we come on to questions is Virendrajit Sandhu, who's a consultant rheumatologist at St George's University Hospital's NHS Trust, who's going to be talking about some of these issues in relation to some particular cases. Virendrajit.
Hello, everyone. Thank you, Sue. I'll just put on my screen. Oh, sorry, doesn't seem to be coming on. Yeah, okay. So I'm just going to talk to you about a series of cases that I've gathered, which hopefully illustrates some of the points that have been raised so far. Okay, sorry, I can't seem to move forward. Okay, so basically the first patient is a 25-year-old black female who presented with inflammatory sounding back pain associated with wrist and knee pain. This had been going on for 2 years. She had a background history of right hip pain for which she was taking naproxen, but didn't find this helpful. She'd had some preliminary tests and was switched to atoracoxib and then became lost to follow-up. This is an X-ray which was taken in the community, which at the time was reported as normal. And actually, if you look, her hips are completely fine. But looking here, there are some subtle signs of sclerosis at the inferior sacroiliac joint, possibly, and possibly some irregularity at the pubic symphysis. She was represented back to medical services approximately a year later and agreed to undergo further testing. She was HLA-B27 positive and had an MRI scan, which was booked for her, which confirmed acute on chronic sacroiliitis with spinal inflammatory involvement. Her disease activity scores, which were recorded in the form of Bath questionnaires, these are self-validated questionnaires which have different questions on a scale from 0 to 10, as well as a standard visual analog scale for pain. Scores above 4 are significant. And as you can see, her disease activity and pain levels were high. This is a snapshot of an MRI that was taken, and as you can see, it shows on the right sacroiliac joint, there is darker areas where there is fat suppression on this sequence, and intensive signal intensity on the left sacroiliac joint with bone marrow edema indicating acute sacroiliitis involving the left sacroiliac joint. So she did have acute on chronic sacroiliitis. The reason I've briefly brought up this case was it's important, as Kirsten mentioned, to characterize inflammatory back pain. Actually, it seems quite straightforward when you lay it out like that actually it's quite easy to make that diagnosis, but getting to this stage took 2 to 3 years for this patient, partly because of difficulty in communication. And it's important that communication barriers such as language difficulties are thought about when you're obviously liaising with people who are from different parts of the world. Also, cultural perceptions of illness. People may present to healthcare services, and particularly women, and then disappear off the system again for a time. So I think in terms of supporting patients to actually be able to give you a good history, and also to then enable them to actually attend for investigations is important, because these factors in themselves can contribute to delay in diagnoses and actually throw any clinician off the scent of actually getting the correct diagnosis. The other important thing is HLA-B27 prevalence. Being HLA-B27 negative does not rule out the diagnosis, particularly in patients who are from a Black or ethnic minority background. Across the world, B27 prevalence differs across different continents. And for example, in West African countries where AS is diagnosed, patients more often than not tend to be B27 negative. And in one study, African Americans, only about 50% who were diagnosed were B27 positive. So moving on to my second case, this is a 30-year-old patient who also presented with inflammatory back pain, but this time it dated back to her teenage years. She had peripheral joint involvement with knee and ankle pain, and also at that time had abdominal symptoms, which were more dominant, and so she was referred to gastroenterology and investigated and confirmed as having Crohn's disease. Back pain tests at the time were unremarkable. She then later had investigations for back pain and had HLA-B27, which was recorded as negative. Her MRI did confirm sacroiliitis, and in fact, at this point, she was commenced on sulfasalazine and treated with hydrotherapy. And she did well. She remained well for a number of years, but then by the age of 25, had a recurrence of inflammatory spinal pain symptoms. Furthermore, she also had temporomandibular joint pain and also scalp psoriasis, as well as new presentations of uveitis. She had no enthesopathy at that stage. Her case was looked at again, and her disease activity scores were again noted to be high. She was treated with further hydrotherapy and commenced on adalimumab, a biologic TNF blocker, and she responded. During that same year, she got married and wanted to have a baby. And she had a number of questions related to pregnancy, mode of delivery and breastfeeding, and some lesser concerns about inheritance in her child-to-be. So in terms of specifics for this particular patient, the British Society of Rheumatology produces some good guidance in terms of the use of immune suppressives and biologic therapies during pregnancy. And this patient had been taking intermittent non-steroidal anti-inflammatories on an occasional basis. Her Crohn's disease, after the initial presentation, was actually really well controlled thereafter. And so she was able to tolerate these. In terms of specific advice for this patient, sulfasalazine could be continued. It's safe to take during pregnancy, conception and breastfeeding, but it's often taken with higher dose folic acid at 5 milligrams daily, rather than over-the-counter folic acid, which will be 500 micrograms daily. In terms of the guidance with respect to biologic agents, there's evidence about the different agents about their use during conception and pregnancy. And actually, with respect to adalimumab and another monoclonal antibody, infliximab, these can be taken at conception and during the first and second trimester. And they may also be used in breastfeeding, although the data is a bit more limited in this instance. In terms of the third trimester, we try and avoid it, partly because of the fact that these monoclonal antibodies can cross the placenta into the fetus and accumulate within the fetus. And actually, on occasion, if there is a patient with spondyloarthritis who does flare, they may need to restart their biologic during the third trimester. It's important to bear this in mind because then when they do have their baby, they need to avoid live vaccinations within the first 6 months of their life, okay? And in terms of family history, well, the only specific history that was relevant was that her father and her father's brother both had psoriasis. And although she was HLA-B27 negative, we did have a discussion around inheritance. Basically, the inheritance is more complex. There is an increased risk if you're B27 positive. It's been proven in studies with monozygotic and dizygotic twins. Environmental factors also play a role, but there are other genes that have been identified. We don't routinely measure these. Examples include ERAP1, and basically it's important to bear this in mind that not everybody will get all of the presentations. And certainly in this lady, she was the only member of her family who had any of these conditions, apart from the psoriasis that I've already mentioned. And finally, moving on to my third patient, this is a 40-year-old lady who actually had a 1-year history of general aches and pains when she presented to healthcare services. Her main symptom was fatigue, which was quite extreme, which was happening all throughout the day. She'd had preceding flu-like symptoms and disturbed sleep. She denied any particular stiffness in her joints, but had achiness and pain all over. She did have some stiffness in the lower back. At that point in clinic, she looked tired. She was noted to have 12 out of 18 myofascial trigger points, but initial investigations were actually unremarkable, and she was diagnosed as fibromyalgia and treated as such. She was referred to physiotherapy and pain team and actually seemed to do really well. She had a good response to exercise and came back feeling more energized for a period of time. She did continue to complain about persistent lower back pain, which seemed to become more of a prevalent feature, or perhaps had not been assessed more in the context of her other symptoms. This was associated with prolonged early morning stiffness. She was started on some naproxen and had further investigations which showed that she was B27 negative. Her X-ray demonstrated some sclerosis at the sacroiliac joints and some possible osteophyte formation in the lumbar spine. She had a further consultation and was switched to atorocoxib, which is a COX-2 inhibitor non-steroidal anti-inflammatory drug. This is an X-ray which shows a quite marked sclerosis, which I'm sure you'll appreciate compared to the X-ray on the first patient. And actually really digging down into the history, she did say that actually she'd been having back pain since her 30s. This was associated with prolonged symptoms of fatigue, difficulty with sleeping, night waking, and moving at night. Getting up to the bathroom helped kind of improve her joints, but she did also have some quite severe plantar fasciitis in both feet. So this is an example of her MRI, which showed high signal changes at the corners of the vertebra, which you can see. So all together, this would be compatible with a diagnosis of axial spondyloarthritis. Her pre-treatment bath scores were quite high. And if you compare that to the disease activity scores of the other patients, the pain levels are much, much higher and actually at the maximum. She was started on etanercept, which is a fusion protein and an alternative biologic agent, and actually in the beginning seemed to do well. Her acute phase markers did improve. But as time went on, the improvement has been, let's say, a bit sketchy, okay? In terms of further points to consider with this patient, as Helena already mentioned, there is a much more of a diagnostic delay with females compared to males. They tend to have lower frequency of typical inflammatory back pain symptoms. And sometimes when they do have the symptoms might be more prominent in the upper spine. Pain can be more of a widespread feature and can be misattributed to fibromyalgia, or fibromyalgia may even be a coexistent problem which can rear its head at different times depending on circumstances. Often they will have much more higher disease activity scores, and the enthesitis can be much more common, as illustrated by the second and third case, and much more severe. This can overall contribute to a higher burden of overall disease, and they can have a worse quality of life, and studies have shown this consistently in terms of data. So in summary, in terms of women compared to men, they may well have different disease manifestations. We can put this down to different immunopathology perhaps, and as Elena mentioned, genetic and hormonal responses. How they present obviously may be different, and therefore we need to be a bit more sensitive to this when we are assessing our patients. They will have much more of an increased frequency of extra-articular manifestations, so we do need to have that at the back of our minds when we are assessing these patients. And enthesitis particularly can be a feature that we can sometimes miss. In terms of women, there are reproductive factors that we do need to take account when we're prescribing medications for women of reproductive age, and therefore it's always best to have a discussion with them in advance about pregnancy planning, and I always discuss that with patients when I first meet them. In terms of treatment efficacy for TNF inhibitors, this is variable compared to your classical male patient who has radiographic axial spondyloarthritis and is B27 positive. And drug adherence may well be not as great, partly because of perhaps lack of response, and partly because actually the medication may not be actually targeting the specific areas for that patient so that they will lose heart and maybe stop the medication more early. The other thing to bear in mind is that B27 prevalence across the world differs, and therefore if women come from a Black and ethnic minority background, being B27 negative does not rule out the diagnosis, and if they have other features which we, after good communication, can elicit, then we do need to bear it in mind. And so we need to be sensitive in terms of language barriers and provide support services to help elicit the correct history in the first place, so that we can actually support patients going forward with investigations to enable a hasty diagnosis and an embarkation on the correct treatment route. I hope that summarizes some of the features. Thank you for your attention.
Thank you very much for that, Bridget. I think it's always helpful to see how things actually play out in actual cases, so that was really useful. If you want to stop sharing your screen now, and we will move to some questions that have been coming up in the Q&A box. We've had quite a number that are about referrals, so maybe ask Kirsten if you want to start by answering some of these. So we've got questions like, well, in relation to the SpA tool, can we quote the tool when making the referral or the request? And questions about whether you would expect GPs or first contact practitioners to have already conducted blood tests, X-rays and requested MRIs. Is MRI better or X-ray better, whole spine and pelvis? So what are you expecting in terms of when you get a referral?
Well, I guess it probably differs in different places. That's the first thing one has to say. So for me personally, I think quoting the SpA tool is useful, or in my area, they fill out the equivalent form. I do need more information about the history. So ideally, I wouldn't want a referral with just the SpA tool ticked. I would want to know something about the story and the history, because that's very helpful for me in terms of prioritizing. It would also be helpful for me as to whether I saw the patient first or whether the physiotherapist that I work with sees the patient first. So that would help us make those decisions. Regarding whether they should have blood tests or X-rays or anything like that. Now, again, that depends upon your area. Blood tests are useful because it's useful for me to know that people's basic organ function is fine, and I like to know what their CRP is, and it's sort of helpful to know if they're HLA-B27 positive. I would say I think a lot of GPs don't like doing B27 because it's quite an expensive test. With regards to X-rays, I personally wouldn't do them because I think MRI is better. And unless there's a standard policy within your area to do the right MRI scan, I'd leave that to a specialist service, because you have to ask for the right sequences. Otherwise, it's a waste of time. So that's how I would look at it in a nutshell.
Great, thank you. And I think one message there is it's different in different areas, which always makes these questions difficult. But do Virendra or Helena have anything to add to that one?
In terms of, from my perspective, I tend to avoid doing pelvic X-rays generally in women of reproductive age, generally because you just need to bear in mind radiation doses. But I think they can be helpful in certain instances, and so you need to sort of bear that in mind. And with respect to MRI, actually, where I practice, actually, MRIs have been done. And I think it depends on local education. The GPs sometimes may well do an MRI of the sacroiliac joints, and that will help pick them up and also make sure that then prompts them on to referral. So often I'm often transferring images into our hospital system and looking at them. So I think it does vary onto different local areas as to what services people can provide.
Yeah, I mean, I do agree with both with Kirsten and Virendra. I think every clinical situation is different. If you are dealing with a young woman of childbearing age, or with a teenager or a very young adult, then yes, MRI either in primary care or in secondary care is probably the way to go. But I wouldn't completely dismiss X-rays. We tend to do a lot of X-rays, and we feel that particularly in those with established disease, they give a lot of information, not only about the diagnosis, but also about possible complications. Yeah? And with the pelvic X-ray, you always have the opportunity to look at the hips. And, you know, a lot of people will have either problems in the lower lumbar spine and in the hip joints. So we do that. We do have some guidance now, and they have been issued by NICE on the, guidelines for management of spondyloarthritis in general that were published about 4 or 5 years ago now. And more recently, the British Society for Spondyloarthritis has worked together with the British Society for Musculoskeletal Radiology. And we have also published some guidance as to when to use MR. I think it's important to realize that, yes, MR usually belongs more on the secondary care setting because of the awareness that needs to be done around the right sequences to ask in order to get the answer to the question you have. But there's no reason why it shouldn't be done in primary care if the GP has got a very clear question, or the physiotherapist or MSK practitioner, if the question clinically is, could this be inflammatory arthritis, then every radiologist in the country will know that they have to look for, they have to add fat suppression sequences or any sort of, fat suppression, imaging to sort of look at the presence of possible acute inflammatory change. So I think every situation is different, but I think we're getting better as to avoid the postcode usage and, to have a homogeneous way of approaching diagnostic, imaging in this country. And I think it's important that primary care relates and communicates with secondary care if they're not absolutely sure. But it's better to err on the side of caution with a young person rather than dismiss it and think, oh, this is highly unlikely. We don't mind seeing young people with a highly unlikely diagnosis, because very often we find that is the diagnosis. So I think that's the main message, yeah? And as we get better with time, we will develop, better referral criteria, but we're still fighting with the fact that in the majority of cases, these people will present with just back pain. And that's the difficulty.
Okay, that's great, thanks. And I think you've answered some of the other questions that were coming through as well, that were about, given what you've said about the difference in presentation between men and women, should we have different diagnostic criteria for women? Should we have lower thresholds of referral for women?
Is that for me or for anybody? That's the $1 million question. And if we had it, we wouldn't need the seminar. Yeah. No, I don't think they need to be treated differently. I think what needs to be different is the awareness and the fact that people, young women can have an inflammatory arthritis. Very often, particularly in the context of psoriasis, a lot of people with psoriasis, either personal or family history, will present with a lot of pain, MCCL type symptoms, very normal CRPs, and largely very normal MRIs as well. Yeah, and we tend to dismiss them, and then 2-3 years down the line, people come with a full-blown picture. So the question is, if we dismiss the presentation, are we creating any damage? And I think the answer is probably not, certainly 100% of the patients. If you look and you don't find it, but it still rings that the problem is inflammatory, just treat it, give it a course of anti-inflammatories, go for the specific exercises, the stretching, and keep an eye on them, yeah? But do not dismiss it. We cannot have different criteria because women don't have anything special about the presentation. They don't have antibodies in the context of axial spondyloarthritis. So we cannot test it, yeah? So I think in general is awareness, and more awareness, yeah? If you think, okay, this could be inflammatory, then you look for the possibility of it being inflammatory.
I think one of the things is so many people think it is a disease of men, that people's awareness or suspicion of it in women is not as high. And really, I think our message is bring down your level of suspicion and think about it more quickly when you're seeing ladies with back pain, particularly if it's back pain come on in their teens and 20s.
Yeah. I mean, I think the erring on the side of caution, I always tell people, and when we do educational meetings, I always say, well, why would an 18, a 20-year-old female who is about to start university, having the whole of her life in front of her, why would she be going repeatedly to see their GPs or their physiotherapist? Unless you're absolutely sure there's nothing wrong, you've got to keep an eye on that person and see how things evolve, because sometimes things take a very long time to evolve. And it's not unusual for females to suddenly turn up in secondary care just after the menopause. The estrogens plummet down, and suddenly the inflammatory response takes off, and they present as a PMR type presentation, yeah? And then we do the scans of the back, and we realize that, they have had established disease for a very long time. And for instance, another presentation which is unusual is persistent peripheral enthesitis. If you have a person coming to your clinic with recurrent plantar fasciitis, or recurrent Achilles tendonitis, even if they work on the beat, even if they're policemen or people standing it in the kitchen, sometimes you have to be asking yourself, why would this person have a bilateral problem that is not getting better? And ask about the back, check the CRP, and those will give you clues as to whether there is more of an inflammatory rather than a mechanical type problem.
I think the other thing that occurs is sometimes it's not picked up in younger people because younger people are exercising more, they're playing sport more, and they're managing their spondyloarthritis. And it's only when they get a little older and perhaps a little more sedentary, or perhaps they change their job, that suddenly it becomes much more obvious. And so they haven't necessarily, in some cases, come and sought help before, because they've just put their back pain down to a strain, or, well, I've just been playing X, Y, or Z, so no, of course I'm going to have back pain. So
absolutely, absolutely. Which is one of the reasons why, well, males before, certainly when I started, as a consultant, we used to have, a lot of males in their 50s, 60s that were starting to come back to see us because they had given up work. And the moment they became more sedentary, suddenly it's like, oh my God, I forgot I was told years ago that I had an arthritis, and it's coming back again. Yeah, and that is typically a typical presentation, definitely.
I think Vindijant's story of the lady who was diagnosed with fibromyalgia, that's quite common. I'm sure you've seen that, Helena. People misdiagnosed as fibromyalgia, particularly women.
We see that a lot, and I get quite upset about that, because we always must remember that fibromyalgia is not an easy diagnosis to make. I mean, I took a very long time as a junior person to feel confident diagnosing fibromyalgia, because it is a diagnosis of exclusion. And an awful lot of middle-aged women that are labeled as fibromyalgia, they've got inflammatory osteoarthritis, for instance, and that hurts a lot. And they may be a little bit hypothyroid, or they're on the verge, of being vitamin D deficient, and they have a little bit of malabsorption in the small bowel, and, they don't keep enough folic acid, and they're B12 deficient, and so on and so forth. So we cannot fix the world, but in rheumatology, and particularly in the context of this particular type of arthritis, it's about understanding that, the majority of the times is the sum of little bits that make a huge big, yeah? And in my experience, a lot of these people that have been seeking advice and seeking help, they are more likely to come to us with really well-established, mental health issues about what's happening to them, than if we see them earlier on in the disease presentation. And something I always tell people when we make the diagnosis of Axial SpA, for instance, is I always say, if you're going to have an arthritis, this is a good one to have, because the moment you understand it, you can do something about it. And if you keep, if you keep flexible, if you do as much exercise as possible, if you avoid smoking, if you just sort of learn how to manage your flares, you are very likely to do extremely well for a long time. And I think this is what happens a lot with females, that we don't talk enough with them. And by the time they come to us, they think that, the wheelchair is around the corner.
I think there's also something else to say. If you delay your diagnosis in young people, it's at a time when they are getting their lives on track. They're going to university, higher education, starting their first job, meeting their partner, having children. And if you don't get it right at the beginning, and people feel constantly dismissed and haven't learned that actually they need to move as opposed to sit still.
Absolutely.
And by then it's stuck. And it's very difficult to get them out of that situation. So it's so important we pick it up.
I think the other issue to bear in mind is that when female patients eventually do present, particularly with sort of fibromyalgia type symptoms, it may be easy to actually say that that is the diagnosis, because then there are accompanying levels of high anxiety, because patients feel as if they haven't been listened to, or they've been discounted along the way. So I think it's important to just bear those things in mind.
And never underestimate that, even if you only have 5 minutes in your consultation. If your only question to a patient is, what one thing would you like me to do? What is it that you've got, you want to ask that you need to get out? Because that is when you're going to make the difference. I've seen an awful lot of people, for whom a good chat, a referral to the clinical psychologist, and then understanding what was the problem once we showed them the images, did much better than any biologics. I've actually stopped biologics on people who actually thought, I'm coping with this. Mm-hmm. And we've been following you now for 15 years, and you've hardly had any disease progression. We can entertain those chats. As doctors, we don't have all the answers. Yeah, and I always say that, look, I'm only a doctor. I can only do so much with the information I've got in front of me. But please believe me when I say that with this information, I can give you a very well-informed guess, which is, you're likely to do well, but you're not going to be pain-free. You may have a degree of, pain, and that you're going to have to adjust to, or you're going to have to do things about. Because you must remember as well that the level of pain that we treat is not necessarily anti-inflammatory. We usually get rid of the inflammatory back pain very quickly, but then people may have other pain, which is mechanical type pain, because they've already had a problem in the back. They've got a disc, which 70% of the population in this country beyond 40 will have this disease, and they may have facet joint problems, they may have any other issues, and sometimes they don't even have the mechanical problem. They may have just sensitized their pain. They're so used to not being well that they understand that at pain. And that pain cannot be treated with painkillers. I don't know whether I make myself, I can explain myself. So there is a lot of art in all this, but it's for us as clinicians, it's about unraveling more or less where the problem comes from. We cannot do that 100%, but we can certainly try.
I think it's also about empowering patients. I think if you get a diagnosis early, then actually a lot of the pain, anxiety that can develop, particularly chronic pain, you can actually sort of kind of halt it in its tracks a little bit. And if you empower patients, like you say, Elena, that can actually help patients sort of manage themselves so that they need to use other medical services less. So I think that's
absolutely. But I think it's a matter of confidence, isn't it? I think it's like in the back of the mind of everybody's minds will always be like, oh, how about it? What about if they're missing something? What about if I'm not saying anything and this must be bad because it's still here? And I think in a way, when you establish a rapport with a patient with chronic disease, you are able to have very deep conversations to say, look, your inflammatory markers have been negative for years. Your x-rays have hardly moved. You are able to do this and that by yourself. And I think that is important. We have to empower patients to take their decisions. I mean, nannying people, bringing them to hospital often only because we don't have the time to discuss things in one appointment, doesn't necessarily sort the problem out.
I also think it's quite important to explain that there is a range of different severities of this, because people look on the internet and think, oh my goodness, this is going to be terrible for me. But if you can tell them they're in a better category, then that's very helpful, I think, for people's managing things. And the other point is really your point, Helena. They may have spondyloarthritis, but they may have other stuff as well.
Absolutely.
They're just as equally allowed to have osteoarthritis as any of the rest of us. And it's understanding the differences between those pains and presentations so they can manage them in different ways.
Yeah.
And the only final point that I want to make is with respect to vulnerable groups of patients, sometimes you can't rely on them to keep presenting to health services, because we sort of think, oh, well, they'll seek help if they need it. And it is important to actually bear in mind patients that you see as health professionals and actually say, what happened to that patient? Let me give them a call. Let me find out. Why have they had their blood test as yet? So all these kind of little factors will help people not drop off the system and, get lost and then re-present many years later when they're much worse.
Mm.
And the COVID situation might help us do more remotely for this particular group of people, so they don't have to charge up the hospital the whole time.
Mm-hmm.
That's we've overrun slightly, but I can see in the chat box that people have really found the Q&A bit useful, so we probably will wrap up there. But thank you very much for joining, and thank you to all three presenters, because it is clear from the amount that's come in the chat box and the Q&A that people have really found this very useful webinar. So thank you all very much for joining us today.